Time now for this week's Health Matters. PA Lynn Szabo in the Fug House. I'm Paul Critz, and today's topic, this is going to be a tough one. I'd like to talk about what you had talked about off mic before we began about how we even have a right to address an issue like this.
Absolutely. So starting out, we're talking about racial disparities in medical care. And let me define disparities, and I will totally get to that because this was a hard one to write. Mm-hmm. You know, I thought about writing it daily for, rewriting it daily for like 2 weeks.
Wow.
Because there's the superficial, which is kind of what I wrote about. And
sort
then
of like facts and figures and numbers and
right,
things.
let's define disparity, all that kind of stuff. And then there's how you solve the problem. And actually, it's not really us. We're the foot soldiers in this. We're not the leaders.
Mm-hmm.
So just define disparity. So an increased burden of an adverse health outcome with a specific subset of the population. And so this exists on the level of the patient, the provider, and the system.
Mm-hmm. Just
so
across,
huge, widespread, really from really personal little tiny things to probably nationwide, probably worldwide. So it's worth mentioning that the main racial and ethnic groups in Del Norte are Native American, African American, Hmong, and I left off in my notes, Hispanic. Yeah, so it's a group I work with often. So how does this affect the patient? So medical science has always kind of assumed that everybody was the same biologically and physiologically as, a 24-year-old, otherwise healthy male medical student. Mm-hmm. Okay, because that's what they use for the normals.
Right,
okay?
right.
And that every med that works on them is going to work for everybody else optimally without any problem. So obviously, more research needs to be conducted because we're a diverse population, and there's there's hugely complex systems within the human body, and we need to see what works best for one group is not necessarily going to be the best. So different screening parameters for disease are based on different genetics. Genetics is probably going to be more and more important. And for example, how you screen people and how you treat people is going to change as we understand the genetics of it more. Okay. So how does this affect the provider? Well, we have 7 minutes in the room.
Right.
So diagnoses, they've done studies on these. Diagnoses are mostly arrived at within the first 7 seconds.
Oh, wow. Just looking at the figures, looking at the person and going, okay,
right.
Yeah, wow.
Well, so you're running risk factors constantly in your head.
I think also, that if you're going to jump in, you've only got like 7 minutes in the exam room. You have to have a rapport. You have to be able to feel comfortable with the person who walks through the door. And if there's any sort of racial barriers there, I think that's delayed then.
Right. And if I've already decided what the person has, then they don't have a voice.
Right.
Their voice is immediately taken out.
Yeah.
So anything that's specific about their genetics or about their racial, or ethnic worldviews or their language, it's all gone.
Yeah.
So, and oftentimes the 7-second diagnosis is wrong. Now I know you guys are shocked to hear that.
Yeah, no, what?
Yeah. So language is another big one. So everybody should be able to tell their story. But what if, the two people that are discussing this story are not even on the same language page? They have interpreters. They have little computer screens where a third party who knows where they are or, what their experience in translating is or what biases they bring is trying to translate. And a lot of patients are kind of okay with that, and a lot of them are super uncomfortable with that. Or you've got a 7-year-old translating.
Right.
Complex medical problems.
Oh my gosh.
Things like that. And there may be things that are hard enough to tell your provider, and when it has to go through a third person, super difficult. Okay. I wrote here that among examples, so in the exam room, when I'm working with somebody who doesn't speak English because they speak Hmong, it's not, my understanding of that language is it's not as direct as English, and you kind of have to I don't even know how to explain this, but it's circuitous. And so oftentimes you'll ask a question like, I'll say, does your toe hurt? And then you'll get lots of discussion going on between the patient and the interpreter. And then the interpreter goes, no. So, you have like paragraphs of discussion going on, and then it boils down to a one-word answer. And as the person who doesn't speak Hmong, I wonder how they got there.
Yeah,
you know?
That's interesting.
Yeah, so it's super frustrating. Okay. Let's see. How does this affect the system? It needs to be addressed more in medical school. That would be my opinion. Nurses have way, way more cultural competency type classes and education than medical people do, at least in my training and the training that I've seen since. Okay.
Just those forward-facing people skills, sort of? Is that what you're talking about?
Yeah, and having a clue that the white male perspective.
Gotcha. Okay, yeah.
And power differential might not be representative of the patient,
right,
who's not in that group's worldview. And
nurses would know, wouldn't they?
Yeah.
I mean, I know there are male nurses and all, but just historically, just the gender bias in the industry.
Right. I think they tend to advocate for the patient more, actually.
That's interesting.
Nurses are big heroes.
Oh, yeah.
Yeah, that's not discussed enough. But I think they're also more intuitive, and that's encouraged in their selection process. So that's good. So one example, when I wrote this, medicine needs to pay more attention to where people might be coming from and how they interpret health. So I specifically put that in because Dr. Martinez, Antoinette Martinez, herself, initially an RN and a nurse practitioner, now a physician working for UHS in Humboldt County, at that time was giving a presentation to the Humboldt Del Norte Medical Society about considerations in the indigenous community and how that relates to health. So oftentimes their life expectancy is much lower and their medical outcomes are much worse. And I know in the exam room, because obviously a population I work with a lot, they are sometimes really not interested in what you have to say, but super interested if you can get them to a spiritual healer.
Really?
So their worldview is like radically different from anything I've experienced before. And I have to say I don't quite always understand it, but anything I can facilitate, I mean, any of the providers at UHS would facilitate that.
Is that something you can do? Can you get them in touch with
There is a spiritual healer that's contracted with UHS. I don't think he's talked about very much. They had a local man. And for some reason they parted ways. I don't really know why. And now they're doing telehealth with a medicine person from another tribe. I think he's Sioux, some branch of Sioux. I don't even know in particular. But when he gave a presentation to the providers, he identified himself as a familial descendant of the medicine person that took care of Sitting Bull.
I'll be damned.
Personally. So high status within the community. People really react to that positively, but kind of hard to get people scheduled with him because by telemedicine, I assume he's working with a lot of different tribes in a lot of different places. So
I would love to do a segment on this guy. Wow.
Oh, he is so cool.
That's really interesting.
He's so cool. But heads up, he doesn't always answer the question you might be asking. So it's the way he speaks is like unlike any other medical person I've ever talked with. So super exciting.
That is interesting.
Yeah. I don't think any of my patients have actually got to see him yet. It's been a while, so I'll have to check in with that. So what does this mean for Del Norte? So we need to find a way to educate bright local kids. So in the Hispanic community, the Hmong community, and the Native community in particular.
Educate them in what?
Educate them in science. Support their dreams, because that doesn't happen for any kids in Del Norte. And hopefully go to school in alternative settings that might be more targeted to, say, math and science, which are skills that you need to get into medical school. discuss more about how to go to school in Cuba, because remember we did
Right.
that segment, and those were being female, indigenous, and underfunded was actually things that they look for in medical school in Cuba, especially people who would like to come from their community, get their training, and then go back to their community. And remember, the training was in Spanish, so even an indigenous person might be coming back having learned medicine in Spanish,
Right,
which would
right.
be helpful here.
Wow.
Let's see, have more bilingual but heritage speakers in the clinical setting. And there's a super exciting development I may have touched on previously at Del Norte Community Health Center, where the center manager is now a local woman who is Latina, heritage speaker, rural, grew up in Smith River, knows the community, has worked in Del Norte Community Health Center kind of structure for a long time, and now is kind of at the head of the ship.
And who is it?
So her name is Anima Dominguez, and I know her because she worked really hard with me on Teen Clinic, but now she's got this broadened experience. And I'll talk a little bit more about why, in particular, she brings us an opportunity.
Great, yeah.
So current providers of all levels should be required to have cultural competency education as part of their ongoing CME or continuing education. I hardly ever see this. I spent a lot of time, studying like COVID or OB or the role of aspirin in high-risk pregnancy and stuff like that, and not really the cultural worldview. And I think that this could be easily done and required, because we have requirements for pharmacy specifically. We could have requirements for cultural competency.
Wow.
Wouldn't be that hard. And there's also specialty medical study in school. Like urgent care, for example, is now something, if you're a physician in your state, like you specialize in cardiothoracic surgery or orthopedics or gynecology, you can also specialize in urgent care. So they could do this and have somebody specialize in maybe, cultural competency kind of issues.
Yeah,
And
that would be
I've
really
never
helpful.
really seen that happen. So it's possible it's happening, and I just don't know. And I think providers should have more time than 7 minutes.
Right.
It's not really enough for anybody. So
what's that mean? How do you address this? I mean, do you think about these sorts of things in the exam room here in Del Norte? Do you, is it...
yeah, I thought about it yesterday when I was in acute care clinic, and I saw a primarily Spanish-speaking person who I know from the community who went to the emergency room, had a complex problem. The communication made it so that he didn't really communicate a full history, because quickly the kind of focus of his visit was taken in a completely different direction.
Okay.
Kind of a dangerous different direction.
Wow.
And so his care just like spun off in like this weird thing. And I was able to talk to him. He speaks both English and Spanish, but his preferred language is Spanish. And I was able to talk to him because I've talked to him about other unrelated things before, and we have kind of a good communication set. And I got a whole different picture of what he was there for.
Wow.
Completely different.
Wow, right there, yeah.
So I asked him if the physician spoke Spanish, and he said only a little bit. So I don't think anybody made a mistake. I think that was a misunderstanding.
Right.
And sometimes it's intimidating when you don't speak, the native language, and or that native language of the person who's your provider, and you don't want to like object to things they're telling you. You want to be a docile, good patient, even if you know like this doesn't make sense to me. So
in our community, does the the existence and prevalence of an organization such as United Indian Health Services, does that change or alleviate that sort of scene that you might find elsewhere? In that there's a place in every community in Del Norte for Indigenous people specifically to go. Is there a greater understanding then of those differences in the UIHS setting?
Yeah, totally. But I also think outside of the UHS system, there's a lot of feeling that, for for people who can't go there because they're not indigenous, they see that entitlement as kind of leaving them out. And I think what they really need to understand is that medical care at UHS, in my understanding, which is changeable, is dependent on treaty rights. Okay? So these people aren't being demanding or entitled or obnoxious. They are insisting that treaties that were written like 150 years ago be honored.
Yeah.
And nobody ever thinks of that. I mean, it blew my mind the moment somebody brought that up.
I didn't know people even had an issue with UIHS and its quote-unquote exclusivity for indigenous
and
population.
there's actually providers, they feel like the patients are too entitled.
Oh my
they do
God.
get more resources than, say, Joe Average at Del Norte Community Health Center.
Right.
But they also expect more services. And I think we have to understand that these were promised in perpetuity.
Yeah.
So like forever and ever. And this is an example of a system that's, I think, doing really well to deliver on it. The other thing UHS does really right is it's led by indigenous people, especially local tribes. And they're super clear on what they need, and they're super focused on getting it. And I think that's totally justifiable.
Who funds it?
Federal government.
That's great.
It's a federal system.
Yeah. Right, because they're dealing with a sovereign entity, right? Yeah. Okay.
Right.
Wow.
Right, and that's who was in the other part of the treaty, right?
Who signed on the other
Who
side.
signed.
Underneath it says "cite."
So I want to talk about this. Kind of leads into something called intersectionality, which is an important, factor to consider, and that's how people's healthcare or maybe their experience in the community is affected by multiple classifications that they have that kind of become not just additive but multiplicative.
Right.
So like 2 + 2 = 5 kind of. So in Annabelle Dominguez's situation, she is a Hispanic woman who grew up rurally, primarily a heritage speaker. And so she has a lot of things that could have gone against her. She worked initially as a medical assistant, kind of worked her way up the chain. And I think that she is an example of somebody that has multiple faces, air quotes, in the community that bring in a unique understanding that she has that's maybe more than, say, random white administrator male who moved in from San Francisco because he wanted to live where the redwood trees are.
Well, and it would be more than even if she had grown up in an urban setting and then came here to work, because then she wouldn't have like that rural side.
Yeah,
of
the
her
rural side is part of this and super important. And I think the same thing applies to a lot of the Native people, especially the Native women who are running the local clinics at UHS. So I think as I'm an urban, educated white woman of a certain age, and I see my role here, I don't know if you'd agree with this or not, as being in the back seat, as being the foot soldier. And my job is not to be a backseat driver. Because I got hundreds of ideas. We could do this, we could do this, we could do this. And it's coming from a well-meaning intention, but it's not necessarily the best solution for somebody else's problem.
Right.
My solution is not theirs.
Yeah,
You got that?
But on the other side, too, I mean, if you want to break it down as simplistically as that, as us versus them in a big sort of historical, metacultural sense, we are part of the problem as well and part of the system. And so how do you then apply that foot soldierness to being kind of on the inside of the system as well?
Right.
I mean, that seems
it's
like
super difficult.
And that's something
it's
that
like
you have
trying
to
grab fog. It's super difficult.
Yeah.
And
but at the same time, it seems like that's underlining all of the interactions and the decisions you make on a daily basis in the exam room. I mean, that's where that gets expressed, right?
So being aware of it, I think, is a good thing. Listening is a good thing. More than 7 minutes is a good thing. And here I am listing good things that I guess maybe somebody in a different position could argue with. I'm only guessing at what their experience is. But trying not to center whiteness, trying not to center privilege, that doesn't mean I'm less than. That doesn't mean I'm, like somehow damage is being done to me because
Right.
somebody has a different idea about how they
Yeah.
want their health care.
Yeah.
It means I have to be patient and understand that I'm not the spotlight. I'm not the director. So I think that's really, really hard for people. And I've heard providers in this community say they can't even go there.
Wow.
They can't even entertain the conversation.
Wow.
So, and I could see where, at best it would be annoying, and at worst it could be like destructive. Like the patient I saw yesterday, we missed an opportunity for a correct diagnosis.
Right.
I'm not even sure I have the correct diagnosis, but I think I'm a step closer.
Yeah, a little more complete picture. Yeah.
Maybe.
Wow.
Yeah.
Well, I know exactly what you're talking about. Being in media and youth media specifically, funded by the California Endowment and part of all these youth media networks around the state of California, very much that statewide drive is to address, inequality and inclusion issues across the board. And so that's going to not be a white issue. And many times I find myself in like conference settings, I'm the one white guy, older white guy in the room. And okay, and yeah, you take a back seat, you sit in the back. This is not your
You try
fight.
and learn something.
Right.
Yeah.
Right.
Keep your mouth shut.
By definition, it's like other people need to drive this issue just
Right.
because of the issue itself. And so you're like, all
Completely.
right, yeah.
But how do we advocate as allies, though? I mean, how do we advocate? Well, of course, we educate ourselves, but at some point we have to use our voice and what we're learning.
Yeah.
But not controlling the situation.
Contributing to and
Yeah.
not trying to control. Exactly.
Yeah, we have to use our voice in respectful ways. We have to defer to a better power structure. We're not the power structure anymore.
Yeah, yeah, and
So-
it's almost, and this is going to from the inside. This is a old white guy talking, but it's even if you know best and you know what the answer would be, it's not the best because it's you having it.
Right.
Other people need to have those.
Right.
Ideas.
You know how you would do it. And so-
Right,
Yeah.
right.
And you might think that's the best. But
Yeah. But you
since I started working at UHS, there's so many insights that I've been like, whoa.
Like.
So that I never would have ever guessed. So the treaty rights thing was
Right.
a big one. And I might not even have that right because it's not like anybody has time to sit down and catch me up to speed. They really are driving this car. They are driving it to their best interest, and I respect that.
Yeah. Yeah.
So
Yeah. And that's the definition of the whole conflict of the whole issue. Is it's just time for people like us to step back.
right, but not completely because I think we're good foot soldiers.
Yeah. Yeah.
And I think we can say, yeah, like they said, and kind of voice support
sure.
without taking control of the dialogue.
But it's like a common joke when somebody says, like, "Oh, I'm going to change things from the inside," and it never really happens.
No.
Yeah, how
No.
can we really change things from the inside, or is that
Yeah.
even an issue? Is that something that even needs to happen?
But I missed an opportunity. I'll just admit it. When a colleague said she would never work at UHS because they're too, quote unquote, too entitled, and I
Wow.
completely missed an opportunity. Yeah,
That's
legally entitled.
Right.
Yeah.
As per international treaty. Yeah.
Yeah.
Wow.
So,
My goodness. Well, so I guess that, like everything else, this just boils down to healthcare for all. It's a right and not a privilege.
right, and it's a right to have it in a way that makes sense to you culturally, and I would say, like, we're so far away from that. Maybe today we could solve for linguistically or something, but yeah, we have to have a really different, super frustrating, completely confounding, respectful way of looking at this in a different way.
And for me, this always sounds like I'm trying to undermine the very real tragedy of American racism. But it seems like the more equitable way to deal with so many of our issues, and I think healthcare is one of them, is more along class lines. because class lines are also parallel racial divides and historical, things that have happened. It just, that seems the way to float everybody's boat all at once, as if, who's poor, who has lack of resources and lack of access to those resources. And that lack of access to those resources also includes having somebody who understands your culture and how you talk.
So I left that out on, that's an important factor in intersectionality.
Mm-hmm.
So I'm thinking more and more that might be the key.
Right. That
is understanding
poverty.
that better.
Yeah.
Yeah.
Poverty and the barriers to resources,
right?
Being the thing that kind of everybody shares. Disproportionately, people of color have more of it, but everybody shares too.
Right. Yeah.
So
absolutely.
So I just it's and I don't suppose. I mean, so this is something like a conscious thing for you then every day.
I try to, yeah. I try to make it a conscious thing. I think racism is so insidious and so, as a white privileged woman, that's how I grew up, that it's my responsibility to wake up every morning and see how I could look at it differently.
Yeah.
And then make sure that I'm not looking at it, from a position of white centrality and white privilege. How do I understand something differently from somebody else's point of view?
Exactly.
And if you think about it right now, what we're doing now is kind of called soapboxing. And
two white people
virtue signaling. Yeah. Like, are we so groovy? You know? So, I think we have to wake up every morning and think about how we're going to do it differently without taking over the process.
Well, I think the best way to address all these issues is to demand to see the manager.
Ooh, sounds very Karen to me. Yeah.
Well, Lynn, thanks for this. This was really, really thought-provoking. This was interesting.
Yeah, I struggled with this. Mm-hmm. And anybody that has any feedback on it,
right.
I'm willing to listen to what you have to say.
Especially somebody who might not look like us.
Yeah.
Right. All right. Well, that's it for this week's Health Matters. And I was surprised by this. I know you've sent me the emails, and I just lost track of them. But the emails for the next week. What's the topic? I forget.
No, I just flipped.
You didn't send me one for next week?
No, but I'm thinking about talking about vasectomy because it's in the national news. I know.
Why is it in the national news?
Because a lot of men are stepping forward in the absence of reproductive justice for women and suggesting this might be a way to go. And it's something that's not accessed here very easily.
Really? Is that another thing that's...
Yeah, not as scary as you would think.
Do you have to go to a urologist for this?
No, you do not.
Okay.
Mm-hmm. And sometimes they come to you.
Well.
Yeah.
Right.
Whoa. But, we'll see.
Right.
I also might talk about fentanyl, which... was up and personal with me and with a patient yesterday. So
right.
It's on my mind.
All righty. Well, thank you so very much, and we'll talk with you next week. It's Health Matters on KFUG. Thanks, Lynn.
Thanks.